What do you do to take care of yourself?
Welcome to the Unfiltered Healing Podcast with Dr. Rachel Hamill.
I ain't Dr. Phil. I'll truly help you heal your mind.
Connect with alternative medicine innovators that will challenge and empower you.
It has the potential to change your whole life.
Create natural balance for both your body and mind.
Your health is very important.
All while uncovering the truth behind modern medicine.
This is crucial.
It's raw, it's real, and it's unfiltered. Here's your host, Dr. Rachel.
All right. Well, Dr. Nora, welcome to the Unfiltered Healing Podcast.
Hi, thank you so much for having me. I'm looking forward to being here.
Well, we're honored to have you on today and excited about the topic we're going to talk about, which is pediatric airway dentistry, because it's truly preventative medicine. And it's something that I personally wish that I knew as a child, so I didn't have to go through all of the things as an adult. But it's also just, a very interesting, amazing section of dentistry, knowing that, the mouth gives us so much insight and many clues about health starting really early in life. So when you entered into dental school, did you know that you were going to specialize specifically in pediatrics, or how did that kind of evolve for you?
Yeah, so my life journey is pretty interesting. All throughout college and my undergraduate years, I was actually a children's birthday party entertainer. That's what I did to make it through college financially. Yeah, it's pretty funny. So the Disney princesses, all of those things, that was me. So naturally, when I went into dentistry, I gravitated towards kids because I felt like that was my gift and my purpose, and that's what made me feel good and made them feel good. And I also noticed that when I was able to treat the little ones at young ages, they were able to tolerate dentistry more, be more desensitized, and have a more positive outlook on dentistry and medicine as a whole with having those positive experiences. So definitely wasn't intending to go into pediatrics, but it kind of fell into my hands, and I advanced into pediatric residency thereafter.
Right. And then you specialized in pediatric dentistry with some other types of specialties as well. Was that like once you were kind of there and interested in it, or how did that evolve?
Yeah, so when I went into residency, I was in a residency program where we were one of the only two specialty departments in the entire state, actually. Meaning that state for any school department in dentistry had only two specialists. It was orthodontics and pediatric dentists. So we would do the root canals, we would do the extractions, the oral pathology. We were doing so much. And because of that, the orthodontics department would send us something called premolar extractions. And that's because they were doing orthodontic work on kids that had very small jaws. And what they noticed is that because they had so much crowding, it would take too long to try to make the mouth bigger to fit all the crowded teeth. So they would send the patients to us and say, hey, there's just a really small mouth, and we want to make the teeth look good to fit the small mouth. Can you take out some teeth in order to make the teeth fit the mouth? So I had one, and imagine you're straight out of dental school where you were learning what the cellular level of dentistry, the procedural work, and not so much the overall health aspect of what you can do to a person's growth and development. And I had one mentor that came to me and said, Dr. Nora, take your hands off of those forceps. You have until 5 years after the age of maturity. They do have 5 years after the age of maturity to come back and sue you. And I said, I don't understand. Why would anybody come back and sue me if the orthodontist is telling me that I need to do this to help the child's teeth get straight? And she said, there's something called airway dentistry. I want you to look into it. Go ahead on your own and start understanding more about what you can do to help your patients' growth and development. And I listened. And although my classmates decided to take those premolars out because that's what the orthodontist told them to do. I decided not. And I learned more about something called palatal expansion and why it's important not to take teeth out in people of small jaws. And that's because of the airway. And what I learned is that our jaws are directly influence how we sleep and how we breathe. Meaning that when we have small mouths and small jaws, that creates a narrow airway or a narrowing of the airway for us to be able to have air pass from our nose to the back of our throat and to reach our lungs. So these patients had crowding, but it was really a symptom of something greater. And that symptom is a sign that the bones were small, secondary to an airway issue or potentially a tongue issue. And that in order to treat the patient as a whole, what we should do is assess for those things and create more space to better help the airway rather than hinder the airway and potentially lead them to a consequence of having sleep disordered breathing and so on. And that was starting my journey. Since then, I've advanced my expertise in myofunctional therapy. I got a certification, and then I became a MyoBrace certified provider, followed by now an instructor, and I educate with them. And I also have advanced expertise in sleep, breathing, ankyloglossia, and expansion and early interceptive orthodontics.
Yeah, that's amazing. And we'll talk more in depth about those specialties in just a moment. But I think it's so important because, you hear like, oh, yeah, that was a long time ago. They used to pull teeth and do things that way for people's mouth. And you still kind of hear that. But, it still happens. Like, people still do it. I mean, thankfully, there's education and like, what we're trying to put out there is more education on it. But it does still happen. And you are kind of, the outlier that said, no, I'm going to do more work in this and learn about this. But is the reality that there's more heavily focused still in that model, the previous model?
Yes, absolutely. And it's just interesting because we have so much we're in this technology era where we have like everything at our fingertips, like the world is an encyclopedia and you can learn about anything. Meanwhile, it's still unfortunately in many sectors of dentistry, people are a little bit behind. And it's not because the research is not there, because there's a lot of research showing that this is the optimal way for patients to grow is by doing the expansion, bringing the jaws forward, helping the airway, tongue, and sleep, but they still miss things. And meaning that and not all, but many orthodontists, unfortunately, many dentists miss the bigger picture of the why. And the why meaning, why is the child having crowding? Why are the child's jaws small? And is there a tongue tie? Is there an airway issue? Is there a sleep issue? And how do we help that child as a whole? Because what's restricting the jaws? Because I will tell you, and I hate to digress, but I've had families that come to me with children that are irritable, getting put on ADHD medication. I had one family that was literally about to start taking doing growth hormone injections, had been in endocrinology because the child was not growing. And this is all directly related to sleep and breathing issues. When a child does not go into sleep because of their underdeveloped airways, for example, and I could discuss that more, what's happening is that they're not growing, they're not releasing the growth hormone that they need in that deep sleep. They are not regulating. There's increased levels of cortisol because they're not getting the deep stages of sleep that they need because it's not, it might have quantity. We might have 8 hours, but it's not that quality that we need in order to fully refresh.
Yeah. So before we move on for a second, other than, the teeth pulling part, creating problems in the actual jaw, are there other implications of just pulling those teeth for those kiddos? Like, does it affect other things other than like making their mouth smaller? Obviously, are there other implications of just removing teeth to remove teeth to make room that you know of?
Mm. Oh, I'm sorry.
That's
Not
okay.
that I'm aware of, but maybe.
Okay, I just didn't know if there were, other implications of removing teeth that you're supposed to have, just to make room.
If they're like decayed or unrestorable, it makes sense. If they need canals, it makes sense. Um, but if they don't, then you know, I don't think that that's. If we have other options, let's consider the alternatives, and at least consider doing something in another direction if the child is young.
Yeah, for sure. So, how early do you typically see children, and what are you specifically looking throughout the different ages that you're not examining and seeing children? And those can be two different questions, but what do you like what's the earliest you start examining for some of these things?
Yes, I'm really lucky because I'm in a space where I can see kids as early as birth, meaning parents come to us to see with concerns of feeding issues and concerns with potentially tongue ties. So, and even besides that, I recommend having a patient come and see the dentist at or around the first tooth eruption, so meaning 6 months or by their first birthday. So we're really able to have that holistic approach of just looking at their growth, their development, what their function is, but also asking the correct questions like how their gross motor skills going, how are fine motor skills going, how's speech going, how's the body looking, are there areas of tension, how are they sleeping, what's their overall mouth posture, daytime, nighttime, and it gives us and birth history is really helpful as well. So it gives us a really good ability to have longitudinal look and observation of our children. So we're able to see them at these early ages and track them over time and seeing them honestly even more frequently than some people see a pediatrician. So we're really able to see kids and catch things super early more often than than a lot of pediatricians could. Of course, there are the select amazing few that are able to catch these things, but yes, a lot of times we see kids and so young that we're able to catch things very early on. And
Are there things like externally you look for too? So obviously like all of those neurological things you talked about, and then symptom wise, their sleeping, their mood, all of those different layers. Are there things as well externally you're kind of looking for that, people might catch in how the face is developing? So you said small, but are there other layers of that you also look for?
yeah, I look at overall their face shape to see if it's symmetrical or asymmetrical. I also look at their shoulders to see if one shoulder is higher than the other, if they're looking and turning in one direction over the other, if there's any areas of tension. That could give me a really good idea if there's any areas where they're stuck in their fascia, because that's very connected to how our jaws and our mouths are. I also look to see under their eyes because their eyes can be so telling of so many things. And if there are areas under our eyes that might be darker, this is something called allergy shiners, or a little bit puffier, that can give us an idea of how children are sleeping. So even if a parent doesn't know, a lot of times we know. I also look at their mouths and their smiles. And if children are a little bit older and they have teeth already, you can see if they have a lot of, or if their mouths are puffy. And that gives me an idea of the
Mhm.
oral microbiome and if they might be mouth breathing. And I also look at the mouth in like a lateral view. So from the side. And if I see that the lower jaw is really far back, that also gives me an idea of potentially how the airway might be or how the child might be breathing or sleeping. Or if I see a lower jaw really far forward, more forward than the upper jaw, that might give me an indication how the maxilla or the upper jaw is growing, meaning that it might not be growing to its full potential. And there might be some reason for that. So those are the kind of things that we evaluate at usually every comprehensive visit.
Yeah. Are there questions you also like specifically ask the parents too? So obviously this would be if the child's a little bit older, like, do you see them with their mouth
Yeah,
open
I do.
and
I do a
questions
really
like that?
comprehensive assessment. So my intake will probably take a family 30 to 45 minutes to fill out. But that's how a good way to know if a family is, if this is the right practice for a family. Because I'm looking at the diet of the parent if they're breastfeeding, the diet of the child if they're eating solids. I'm looking at textures. I'm looking at supplements. I'm looking to see if there are any potential deficiencies anywhere. If they've had a naturopath assess their child, I want to know what they're looking at and what the levels are. Any potential exposure to toxins. I just had a family this morning that had mold exposure that has impacted the entire family's ability to sleep, breathe, function, and their toxic load is full. So they're working on that. That absolutely impacts dental health. And I, of course, sleep and breathing, like I mentioned before, and I'm asking questions, but also I'm able to really take a look and know more once I see the child. I'm looking at birth history and history of of trauma, because that gives me an idea too. If we need to work with somebody like a body worker or a craniosacral therapist, an osteopath, to help us in the whole body healing of that child if needed.
Yeah, I will say personally, the mold or like intense allergies, which usually are from mold, uh, in themselves can create developmental airway issues. Because if someone can't breathe through their nose because it's all inflamed, then that can cause facial structures to develop that way too. So that's really important to know those different types of things. Now, you talked about toxicities, diet, all of those things. What do you think? So I know from my standpoint, being a craniopath and kind of my knowledge, but more of your opinion over this matter, like what do you think are some of the potential causes of a lot of these issues early on? So you mentioned a few, like what are some other like hypotheses or causes that you also think are contributing to such a change
So I
in the
have
face
this
and airway
really
in children?
abstract theory, and it's how I start most of my educational lectures, and it's that it all starts before it all starts. So these within embryo, within the womb, we have epigenetic influence, right? Meaning that what our ancestors, what they ate, what they were exposed to, it is going to impact our children within the womb. So just throughout time, our bodies are only going to create what it is that the child needs. So I see many children because I'm able to see them so early on in life, I see many children coming to me with very small jaws from birth, high and narrow palates, which I could discuss more, and the and tongue ties. And I think that's because of now our predilection and industrialization of food, and how we have more processed foods versus more whole foods. And that has impacted how our bodies have grown. So I think if we really look back, I think it really does start before it all starts. And I think that's what's really influencing, one of the things that are influencing our children and their growth and development as well.
Yeah, absolutely. So what about like different patterns? So we can talk if you want to go into the palate and talking about the palate, that would be awesome as well. But what about some types of habits, like for instance, thumb sucking or finger sucking? what are these specifically doing to also the airway and the
Yeah. So
face and the mouth and the teeth?
anytime we have, so what we need in order for our jaws to grow, our goal is to have the tongue up on the roof of the mouth when we're sleeping and during rest to create the optimal growth and development of the upper and lower jaw. So we need to be able to have strength of our tongue, and so that's like the tone, and also the mobility of the tongue, and in order for the tongue to stay up. We also need that in order to breathe from our nose. If our tongue is down and our mouth is open, we inherently breathe from our mouth. So we need that tongue up in order for the palate to grow properly. When we have low tongue posture, pacifier usage, or finger usage for very frequently and a long duration and very intensely, what happens is it can manipulate the shape of the jaws, right? And when we manipulate the shape of the jaws, the floor of the nose is also the roof of the mouth. And I'm going to say that again. So the floor of our nose is one bone, and it's the same bone as the roof of our mouth. So if our roof of our mouth is not growing properly, what happens is, because of whatever reason, whether the thumb, the pacifier, the tongue, and there's a lot of argument or what comes first, but we start to notice that the upper jaw doesn't grow. And that also means that the nasal passages become underdeveloped. So that gives us an idea of what. So when we see the nasal passages not develop and the maxilla being small, that also can cause other future issues and consequences as well when it comes to sleep and breathing. In regards to finger sucking, there are lots of in utero like scans, ultrasounds, etc., of kids, babies, sucking on fingers in utero. And there's some theory, there's an study by Fronte in 2014 that says that when you suck on the thumb or when your tongue is up, it stimulates something called the nasopalatine nerve. And that nerve is right behind the two front teeth, right? And that helps release dopamine and it makes us feel good. That's why kids do it. It helps them regulate. And there are some theories that if a tongue is tied, the child might reach for that nasopalatine nerve to get that regulation and stimulation by using their thumb instead. So we think so I will tell you, my own son, who is 2.5, was a tongue-tied baby, and also his thumb sucker. Very frequently in a lot of
Yeah. So
no
sorry,
worries.
there's airplanes above my office. It was hard to hear that last part from you. But what I wanted to add to that is it that it are because you hear different people say then, okay, well, it's just like the shape of the pacifier, or there's better pacifiers. Is there like one palatal friendly pacifier? Because our mentality is that it's still pushing the tongue down, so the
Yeah.
shape of it can change, but still pushing the tongue down. Is that correct?
Yeah, so there are these like supposedly orthodontic pacifiers on the market. I don't recommend them. I've actually seen in my practice the most anterior open bites and cross bites from these orthodontic pacifiers than any other pacifiers, and that's because they are trying to shape the palate with the pacifier, but that's still not the optimal way. And it also helps keep the tongue down and inherently promotes that low tongue posture. So I like pacifiers in which that the tongue can cup around so that the lateral body of the tongue is still on the roof of the mouth. So that means like things like the Avent Soothie, which I think a lot of kids get in the hospital, or the ninny. The ninny is something I really recommend because it shapes and is felt like a breast, so kids really like it, and it helps with. It also is used as therapeutic tool for a lot of. therapist too. So I think those two pacifiers are really helpful. I mean, you don't know what you don't know. So a lot of parents don't get that knowledge prior to introducing, and it's really tough to kind of switch a passy when you've started it. Kids are not that like not that easy
Yeah.
to right? So yeah, so those are
Yeah.
for your children.
Thumb sucking too.
What?
I said thumb sucking too.
So I
That can
think
be a hard one.
thumb sucking is truly the most difficult to kind of redirect. But I really do believe that redirection of the behavior is the most important thing. Being positive, having a gentle parenting style when doing it is going to create the most positive outcome with their sleep and with their association with it. So I do believe.
Yeah. Yeah. Is it the same for bottles as well, or is it more like the pacifiers and fingers that are bigger problems?
I have seen some kids that have been on bottles for an extended period of time. I've seen a couple, not many. The
Mhm.
thumb and passy has been much more prominent as a cause for these issues. And for those two patients, they were using a bottle past the age of like 4. One was 4 and one was 5.
Mhm.
And what we find is that when you're using the bottle consistently and frequently, it shapes the palate improperly as well. So it's good to transition off of a bottle by the age of, they say 1 to 1.5 is ideal.
Yeah, and obviously there's circumstances that warrant bottle feeding, but we try as much as we can to encourage the breast because of all of these things that we're talking about with the tongue and the palate and the airway. It really is meant to be that way. um, and I know that you guys encourage that in your practice as well, working and co-managing cases together. So let's talk a little bit about tongue ties specifically because you've mentioned those, and that's something that you guys really excel and specialize in over other practices. Now, and it's also gained a lot of interest, I'd say, in the past 10 years. And I think because of the importance people are realizing of breastfeeding and, the airway and stuff of that nature. But um, what are some signs other than, examining and seeing that the tongue is tied for certain parents that a child may need a tongue revision?
What repeat that? If what is something that would warrant a tongue revision? Sorry, I couldn't hear you well.
Yeah, so what are some, so other than an examination that you're doing, like what are some signs that a parent might want to actually get the tongue tie revised?
Got it. So when you're I'll tell you my own personal experience. When my son was born, I'm like, I am going to breastfeed, right? So I put baby to breast, and I was like, ow, this really hurts. And then the lactation consultant looked at me, or I don't even remember. I think it was the nurse at that time. The LC hadn't seen me yet. She's like, it's supposed to be that way the first couple of times. It's normal. I'm like, really? Like, this is super painful. And then I tried again. And I remember just unlatching him that first night. And I'm like, ow, my nipples are bleeding, like actually bleeding. And I couldn't even put it back on because it was just so painful. And then I looked under his tongue, and I never thought my son would have a posterior tongue tie. And I see under the tongue, and of course, lo and behold, like he has this thick posterior tongue tie. The lactation consultant comes in the next day, and she's like, maybe he has one. The OBGYN says, no, he doesn't have one. He's fine. And I'm like, I know, because this is what I do. He has a tongue tie. And my husband, of course, Nora Zaghi, he does a lot of research in tongue tie, has treated thousands upon thousands of patients with tongue tie. We're like, we are getting out of this hospital and we're treating this right as soon as we walk out. And day 2 of life, we did. And instantly I was better. And I had seen I've had these success cases with my own patients prior to me having my own child. But when I had felt it myself, it gave it a whole different meaning. Not that those families seeing their successes didn't give me meaning, because it gave me so much joy and made me feel like we are doing so much for that child. But when I had gone through it myself, I'm like, this really can impact a mother's ability to feel like they can bond with their child, their ability to even feel like that they're a good mother. Because a lot of times we associate breastfeeding with infancy and motherhood and that relationship and building that dyad, because that's what you do when you give, like, that's like your job. You're one of your jobs. You're feeding your child. It's and if those that choose not to breastfeed, that's totally fine. But for those that do and can't because of a physical ability or pain or structural issue, it can be really debilitating to their mental and overall postpartum health. And I had physically gone through that myself. So that's one of the reasons that I think many patients first think about tongue tie, because they might have heard from a friend or a family member that, hey, maybe you should get it checked out by somebody that knows about it. And unfortunately, not a lot of pediatricians, not a lot of OBs have that extra training. If you ask them, they get 1 hour maybe in their entire residency of their 3 to 4 year residency programs in learning a little bit about tongue tie. And they haven't learned many of them haven't learned the most recent research related to classifications, indications, pre and post-op information, and the most optimal ways to treat. It takes a lot of advanced education and experience in treatment in order to do that. So that's why a lot of families kind of gravitate to us in the early days, because of their inability to feed. And once kids get a little bit earlier, I just saw a patient literally 1 minute before we started this podcast who got a tongue tie released by a provider at birth. He got it done with scissors, they clipped it, never did any follow-up. And now he's 18 months sitting in my chair, and mom is at her wit's end because she's seen 3 to 4 doctors a week that are specialists, and her son cannot chew and swallow. He chokes, gags, can't swallow, can't feed him solids. He's still on purees at 18 months, not by choice, but because she's physically scared of feeding her child solids and the fear of choking him. And this is her 3rd child. So it's not that she doesn't have the experience or the knowledge or the ability to understand, but, you know, this is a structural issue that could really impact their ability to feed. Speech, we see that it's difficult to say the R, T, D, L, N, K, and G sounds when there's that restriction. And also in the future, it can lead to, or even in early days, it can lead to the mouth breathing like we talked about and the restriction of the upper and lower jaws. But in those early days, it really does affect them. And what we also need to know on a more in a deeper level is that it's not just the function, it impacts the entire body, because the frenulum, the lingual frenulum, is the start of the fascia system of the entire body. So if you look at a dissection of the deep front line and you do a human dissection, what you find is that we find that our bodies and our organs are lined by fascia. And fascia actually begins with the lingual frenulum, and it lines our ribs and our organs and our legs all the way to our toes, or parts of our legs to our toes. And what we find is that when we do releases, patients are able to breathe better in adults, especially because they have that more understanding and they've had those years of the fascia restriction. They're able to breathe better. They feel like the tension in their shoulders has decreased, the tension in their legs. And that's part of the reason is, I think, the fascia, the relationship of the tongue to the fascia. And that's why I think body work is so very important in even the littlest of kids, because we see many kids with torticollis and tongue tie, and that relationship, there's some connection there.
Yeah, there's an absolute connection there between the craniofacial system and the tongue. So for your, in your case as well, are there some cases that, you know, you may not release a tongue?
Yeah, yeah, totally. So there are cases. A lot of times I see like there's compensations, like the child is reaching up the floor of the mouth, which means that they're like pulling on different parts of the structure of the mouth in order to use the tongue for the normal function. I also see, and that in that case, we don't release because we need them to do myofunctional therapy, oral motor feeding therapy, and working with a lot of times body work before doing any sort of treatment. And sometimes in those cases, it's just compensation patterns, and with therapy, they get better, um, which is amazing. And those are great successes. And other times we won't release when we see the jaws are too small. If we release the tongue and there's no place for the tongue to go, especially when the children are older, then it's really important to work on the structure before working on releasing the tongue. So those are three different times where we would consider putting a pause on release in order for us to gain the results that we want.
Yeah, and that's why I like appreciate and respect your guys' practices so much, is because you recommend and have different providers even in your office, because I oftentimes see children and sometimes they've already had releases done with providers here. And number one, like you mentioned, you need people who actually know about tongue ties thoroughly, because a lot of pediatricians will say they don't. But also, I've had many patients that got the release done, and the mom is like, well, it doesn't really feel much different nursing, or we're still having problems and all of these things. And there are a lot of those compensation patterns that you guys know and you guys realize, and that's also really important to work with kiddos too. It's not always just go, snip it or laser it or whatever, however you do it. You have to look at the whole child and the whole picture of that as well, and that will make it successful for that child. Yeah. So if the child is a little bit older, so you mentioned a little bit about, you're a myo brace provider. So if people don't, listeners don't know what that is, it's more of a conservative measure to help working on expanding the palate. Um, what are some things that you typically recommend? Are there, other than the myo brace, or are there things that you recommend that patients should look for when, okay, they've maybe addressed the tongue tie, but they're a little bit older and now their palate is just real narrow, and so they have to do some type of expansion? What are some recommendations there?
Yeah, so I do all types of expanders. Myobrace is something that I that's in my toolbox when I feel like it's going to help a family. Sometimes I can't just use Myobrace, and usually I use other things as well in with it. Um, there are just traditional palatal expanders. There's ALF technique. There's working with something called removable anterior growth guidance appliance. Um, there's Schwartz appliances. There's BioBlocks. There's so many different appliances out there, and your provider should be able to analyze your child, not only like what how everything looks, but also like what their personality is like, because not every appliance is going to be right for every kid personality wise. Some are bigger than others, some stay in the mouth, some go in and out of the mouth, so they have to be a little bit more responsible. So it's just helpful to be able to be with a provider that kind of has like many tools in their toolbox, so that we can be able to treat them to the best of our ability.
Yeah, and that's a great point, because I think traditionally most people think, okay, well, my child needed expansion, I'm just going to go to the orthodontist and do, like the turnkey expanders, which are needed in some cases for sure. But there are other more conservative options out there. And so it's great to know what those are. But not everybody's going to do the mile brace because, like you said, personality. Some kids won't hold something in
Yeah,
their
yeah,
mouth for that long. So you have to decide what's right for your child.
totally, exactly.
Yeah. Okay, so we only have a couple minutes left. I want to respect your time, but I just had a couple more questions for you on the topic of children. Now, as far as like dental decay in children, so kind of moving, although this also relates to airway, um, what do you think is due to such rapid like dental decay in children? And maybe it's already stuff you've already mentioned and you can reiterate, but because that's also another important thing to really look at in children is the health, obviously, of their mouth and their teeth as well.
Yeah. So functional dentistry seeks to analyze the root cause of a problem, which is the root cause, for example, in decay for a lot of parents when they're looking at their child, the reason for their child's decay. So hypomineralization from a lack of nutrients, for example, when a child might have deficiency in minerals in their body, can also lead to the bone having deficiencies, which can lead to the teeth having like more predilection to having decay. So a lot of kids with like vitamin D deficiencies, a lot of kids with um, what we see sometimes it can affect and calcium deficiency can affect the mineralization of the teeth, which can lead them to having decay. Also, mouth breathing. We need the mouth to have the saliva to act as a buffer. And that buffer of saliva has calcium and proteins that it replenishes the mouth, and it helps uh, create a neutral zone so that decay doesn't it doesn't take over, so bacteria doesn't take over our mouth. Also, diet. I talked a little bit about like the industrialization of processed foods and carbohydrates like cold fish and crackers and these different things. You would think, oh, it's not sugar, but breaks down into sugars and causes decay because it's really hard for it to get out of the teeth, stays in between the teeth really easily, um, creeps up into those grooves and creates decay. So it's important for us to seek the why. If it's hygiene, we need to work on brushing and flossing and products, then that's one. If it's mouth breathing, if it's diet, if it's nutritional disease deficiency, what's the root cause? And we need to work together to resolve it.
Yeah, I heard that the goldfish that a lot of people give kids are like one of the number one causers of, because you see it in like all the daycares and all the schools, everybody has goldfish, but they're so bad for the teeth. And I love that you didn't. Yeah, yeah, right. I love that you didn't start with, brushing and flossing, because that's what you would hypothesize as a dentist, that's what you would say first. And obviously that's a big part of it. But, airway, diet, all of these things that we've been talking about in this episode or the overall health of your child's mouth. Do you have particularly any favorite products that you like for kiddos as far as oral health recommendations?
Yeah, so I think it's really important to see if that kid has like sensory or cares about texture or taste. It's really good to know like if they like mint, they don't like any taste. They like like anything that looks that looks kind of sweet, tastes kind of sweet. So I like Boca for the orange. They have like an orange space kind of toothpaste for kids. I like it for adults. They have an element and a ginger and a Coke, I believe. That's great. Boca is wonderful. I also like Risewell. I recommend it for kids, and they have a cake batter flavor for kids, and adults they have the mint flavor. And then recently, there's been some research that was released on PubMed about Kinder Carex. Has a good amount of percentage of hydroxyapatite. Hydroxyapatite is physically what our teeth are made of. So 97% of our enamel is made of hydroxyapatite, and Rhizol and Boca create their hydroxyapatite from organic matter. So it doesn't come from bovine bone or anything like that. So very cruelty. It doesn't have. It's vegan, cruelty free, and it's a great way to help not only whiten teeth, decrease sensitivity, but also help remineralize teeth. So that's usually those three that I recommend. And if kids have more sensitivities, I have a list of others. There's like something called Carry Free. That's really good for kids that has this like hydroxyapatite version. Um, And yeah, so I would start there and see what works with the child. And there's different ways to actually make it fun. So like some kids need like a fun toothbrush or need like a fun toothpaste. So like grab some stickers from the Dollar Tree and put stickers on the toothpaste and the toothbrush. Like, kind of make it exciting so that they enjoy the process, so that hygiene is optimal. And teaching them the right way on how to do it. Because, I will be the first to admit I didn't even know the right way to brush my teeth until I actually started dental school. Nobody taught me that you have to brush in circles and that you have to floss a certain way and hug the tooth when you floss. So, yeah, spend a minute when you go to your dentist, any dentist that you go to, spend a minute and just say, hey, Dr. So-and-so, I need you with a mirror to show me if me and my child are doing this right. And that can really change their health for the future.
That's good. Those are great tips. Thank you for that. So in ending, where can people find a good pediatric airway dentist if they aren't necessarily local to Los Angeles?
Yeah.
And then, you can promote yourself. How do people find you? I'll obviously put that in the bio and information of our podcast as well. But what are just some resources that people might look for?
Yeah. So, so I do virtual and in-person consultations in Los Angeles area. And if you're looking for specifically an airway dentist, I think it's really helpful to look at the Breathe Institute website. So you look at breatheinstitute.com, and there's something called ambassadors and affiliates. And if you type in your zip code, these are the doctors that have taken our courses. There's ambassadors that have taken the courses and affiliates that have done hands-on training with Dr. Nora Zaghi. And that means they know more about sleep, breathing, and tongue tie. So that's a great way of finding somebody that's more versed in airway, for sure.
Wonderful. Well, thank you so much, Dr. Nora. This has been an amazing, awesome time. Mm-hmm. Thank you so much to you and your husband. You're doing some amazing things at the Breathe Institute. So we're thankful for you and your educational knowledge. I really appreciate it. Thank you so much for your time today.
Today was fun. Thank you for having me. And I hope this helps the families that listen.
Yes. And how can they follow you personally? Do you have any social media things?
Cool. Yes. So my social media handle is at Dr. Nora Zaghi, NoraZaghi. That's my personal handle. And if you want to, follow me, would love to share my oral health tips with you all.
Wonderful. Well, thank you everyone for tuning in, and we'll catch you all on the next episode.